Hola, buenas tardes. Soy la doctora Jimena Varela, neuropediatra y neurofisióloga en la Clínica Las Condes. Antes de empezar el webinar, les solicito por favor cerrar su micrófono porque si lo dejan abierto van a interrumpir la charla, ¿ya? Le damos una cálida bienvenida a este nuevo webinar vespertino en temas de epilepsia, conversando con el experto, que es organizado por nuestro centro y que ha estado durante todo este año. Y en esta oportunidad vamos a escuchar a la doctora Ingrid Scheffer, científica clínica, neuropediatra y epileptóloga de la Universidad de Melbourne, presidenta de la Academia Australiana de la Salud y Ciencias Médicas y expresidenta de la Comisión de la ILAE para la clasificación y terminología de las crisis epilépticas. Ella nos acompaña desde Melbourne, Australia, y les invitamos a formular sus preguntas en el chat asociado, las cuales van a ser resueltas por el doctor Felipe Castro y la doctora Francisca López, y se la van a formular en inglés a la doctora, ¿ya? Invitamos a la doctora a comenzar con su charla.
Dr. Scheffer, the floor is yours.
You can start.
Thank you very much. I'll just share the right screen, I hope. And can I just check you can see the right screen? Yes, I can't see anybody now.
Yes,
yeah,
this
that's
is
great.
proper.
Thank you. Thank you very much. Thank you for the very kind invitation to speak with you. I've been to Chile now, I think 3 times, and always had a wonderful time. So I really wish I could be with you so we could talk about patients, etc. But it's nice to be able to talk to you about Dravet syndrome and our recent work trying to help clinicians to make an earlier diagnosis. Here are my disclosures. So the aim of this talk is really to understand the clinical features of Dravet syndrome and to question what you and I usually teach our junior doctors and say, is it quite right? Or are we teaching them maybe just the wrong things slightly? And so what we've done is take 205 patients and asked all these questions to see what the correct data, what the evidence shows us. And the aim of this is to diagnose patients really early. And I was just able to see how effective this was diagnosing a 5-monther with Dravet syndrome. So I thought I'd start with what we usually teach, and in fact, what I have taught about Dravet syndrome for many years. And many years ago, I decided to make a puzzle about it because it's a complex diagnosis, not based on just one feature. And an example of that is when I was just learning about Dravet syndrome, as we all were in Australia in about 1999, 2000, most of my colleagues, if they saw a child get worse with lamotrigine, they decided it was Dravet syndrome. Their onset might have been, 3 or 4 years of age, which of course is not Dravet syndrome. And that made me think about how can we get people to understand this is a complex diagnosis. So I came up with this puzzle. And the puzzle is around understanding all the bits of the puzzle that have to go together so that you can be confident that the child in front of you has Dravet syndrome. So, as you know, we teach that these children are usually normal, developmentally, a well child, presents at a mean age of 6 months, like this. And this is one of my 2 children I've just seen in the last couple of months with a new diagnosis. And this was just when, in fact, around the time I made the diagnosis. And you can see with the seizure, I apologize for the audio on the video. She's about 10 months old and she's having a very clear hemiclonic seizure with involvement of the right side. So a hemiclonic seizure, I'm sure, would make most of you think Dravet syndrome. So we think of a baby presenting with hemiclonic seizures with fever, And maybe the first time it's down one side, the second time it might be down the other side. So if they present with different side involvement, you immediately should go, could this be Dravet syndrome? We talk about them presenting always with fever. We talk about them presenting with status epilepticus, which is defined as a seizure lasting 30 minutes. And these babies present at a mean age of 6 months. But then between 6 and 12 months, we tend to think of them maybe coming back in every month with a seizure triggered by illness or fever. And in fact, my 2 recent diagnosed babies, of which this is one of them that I've just shown you, have both been doing that. They've been coming in every 1 to 2 months. We then teach that between 1 and 5 years of age, these infants often get other seizure types, including focal impaired awareness seizures. They may have myoclonic seizures. They may have absence seizures. They don't all have all of them. And they often present with non-convulsive status epilepticus, which the French originally called obtundation status. That doesn't work very well in English, and so we tend to use the term non-convulsive status epilepticus. Now, the next one is of a little 21-monther that we were doing photic stimulation, and he had a seizure. I'll let you watch it before I tell you what I was
Here comes Kiki for you. Thank you. Good boy. Good boy. Thank you very much.
Okay.
So he doesn't like that very much because he's having a cluster of myoclonic seizures triggered by the photic stimulation. But I like to let it play so that you can see that it's actually not a tonic-clonic seizure, but just a cluster of myoclonus. Now, only 15% of Dravet children are actually photosensitive. So that's the exception rather than the rule. And that 21-month-old infant I just showed you, or toddler, is now about 20 years old and has severe intellectual disability. Now, I'm just going to show you this little guy. And we won't play that one again. And now this is another little boy who's about 2 here. And you can see that he's having very frequent absence seizures with eyelid myoclonia. You're about to see one now, one where he flutters his eyelids, his head tends to drop. Don't always drop, but there's another one. And there he has a bit of an atonic component and again an eyelid flutter. Now you see the same little boy in the next video here. He's 2 years older. He's wearing a helmet because he often falls. But with this little cluster, you'll see there's some myoclonic seizures in it there and a big atonic component. And you even wonder if he might be having a myoclonic absence, but we haven't really captured that. So there tends to be that you see lots of myoclonus and absence seizures in the more severe Dravet children early on. So it's not a good sign. So the next part of our puzzle is the development. And we teach that these children have normal development until 1 year of age. Then their development slows or indeed they may regress. We did a gait study many years ago now, and we showed that the mean age of walking was 16 to 18 months. So just a little late. Their language development's slow and they may regress with seizures and take a while to catch up. And I've written a catch up like that because maybe they do not catch up. 50% of Dravet children have severe intellectual disability, 30% moderate, 20% mild, and it's extraordinary to have rare intellectual output. I have one adult actually who's had some children and she is of normal intellect. So what about their examination? Well, as you know, they have their physiological ataxia persists a bit longer than it would in most children. But as they get older, they get these mild pyramidal signs, which you will miss unless you examine the sort of 12-year-old again. And they develop this unusual crouch gait with flexion at the hip and flexion at the knee. And despite it looking really severe, they actually can walk reasonable distances in it. They also have plano abductor valgus that you see down here. We showed that as they get older, it limits their long distance walking, but they can run even though they have this, which is amazing. I always think it's amazing they don't fall. Now, the EEG is rather unhelpful in the first 1 to 2 years, because although the baby is often presenting with many seizures, their EEG remains normal, but then after about 2 years of age, they get frequent epileptiform activity, often this sort of irregular generalized spike wave and multifocal discharges. Now, what about the genes? Well, I suspect most of the people on the call know that SCN1A is associated with Dravet syndrome. And here you see a figure of the sodium channel embedded in the cell membrane. And you can see here the alpha subunit, which is the pore-forming subunit. And on each side, it has a beta subunit that helps to regulate channel kinetics and also attaches the channel to the cell membrane. Now, SCN1A, SCN3A, 2A, and 8A have all been implicated in developmental and epileptic encephalopathies, but SCN1A in Dravet syndrome is really the best known. And we tend to teach that more than 80% of patients with Dravet syndrome have mutations of SCN1A, and I'm going to show you that that figure is even higher when you really are precise in your diagnosis. Now, this is quite an old figure, but the take-home message has remained the same, and that is that 40% of patients have truncation mutations, and 40% of patients have missense mutations, and the remainder have deletions, which may just be small inside the gene, or splice site mutations, or some people will have deletion of the whole gene or exons of the gene. The important point here is that I think everyone, it's sort of intuitive that you might like to say, well, you know, truncations are worse because you truncate the protein, you have haploinsufficiency, and missense make genetic epilepsy with febrile seizures plus, which is a self-limited benign disorder. But this is wrong. So it's really important that you don't start thinking it's simple like that, because it's not the case. 40% of Dravet children or adults have truncation mutations, and 40% have missense mutations. SCN1A is a very large protein of 26 exons, and gene with 26 exons. So there are many people with private mutations, their own mutation. Obviously, with more numbers around the world, we are getting recurrent mutations, but there aren't sort of like one major mutation. There are many, many mutations. So I thought before I go into our new study, I'd just spend a few moments talking about inheritance of SCN1A mutations, because this is really important in how we counsel our families about recurrence risk, etc. So 90% of our Dravet patients have a new mutation in the child. You test mum and dad and it's negative, and so it's new in the child, which means that they should have a low recurrence risk unless one of them is mosaic. And I'm going to talk about mosaicism now. And I'm going to spend a few minutes talking about mosaicism because it can be relevant to the patient and it can be relevant to the parent. So here you see a beautiful Australian Aboriginal painting of a lizard. And I like it because they use this dot painting, and these dots are very much like mosaicism. So to remind you about mosaicism, it means that you have two populations of cells. You have normal cells or wild type cells, and you have cells that have the mutation in it. Now that cell, the mutants may be limited just to brain, in which case it's hard to find that mutation unless you have a brain sample, or we have just started to do some research, just published a paper this year from one of my PhD students showing that you can identify a mutation in CSF from cell-free DNA. I wasn't intending to talk about that now, but I'm happy to talk about that in the question time. If the mosaicism is limited to brain, we won't know about it. If the mosaicism, the mutation, happened a bit earlier, it may be at a low level in blood. The other type of mosaicism that is important is if the mosaicism is just, say, limited to the gonads. So here you see again the abnormal cell amongst the normal cells, and it depends on the timing of mutagenesis as to when or which tissues that the mutation will be present. So for this example here, if the mutation just happened as the gonads were developing, the ovaries or the testes, you may have the mutation limited to egg or sperm. And therefore, if it is in that egg or in that sperm, that child will be non-mosaic and will be an affected child. If in the parent it's limited to egg or sperm, then that mutation, the parent will be otherwise entirely normal. So is this relevant, this whole question of mosaicism, to our patients with Dravet syndrome? And the answer is very interesting and is yes. So this is a lovely Dutch study from Bobby Kuhleman's group in the Netherlands, and headed by Iris de Lange. And what they did was they took 113 patients with Dravet syndrome, and they looked at them for each child's mutation. They looked at it a mean of 1,200 times in each child. And the range was 20 to over 7,000. And they found that of their 113 patients with Dravet syndrome, and this was on blood from memory, that 7.5%, 8 of the patients actually were mosaic. And they found, the only difference they found in this was that if the child had a truncation mutation, they were actually a bit milder than other Dravet patients with truncation mutations. Now, this is actually, if you find mosaicism in the patient, it's actually good news for the parents. And that is because this mosaicism, if the patient has a population of normal cells and mutant cells, you know it must have started in that child. It can't have come from mum or dad, because the child has two populations of cells. So that tells the parents that they have a low or minimal recurrence risk. So in fact, finding the child is mosaic is helpful for the parents. I want to move now to the parent issue and talk about some paper we published a few years ago about Dravet families and asking this question about de novo mutations. Now here, you really missed the point, because you want to tell a family they have an increased risk of a second affected child before they have the second affected child, or we're not doing our job well enough. Because by the time these parents have got a boy and a girl with the mutation, you know that one of them must carry it, even if you've looked at their blood and it may be de novo. If, on the other hand, the parent actually has a history of febrile seizures, that is a red flag to us that perhaps this parent is mosaic for the condition. And indeed, in my family like this, their little girl has since died of SUDEP, but the father was mosaic and he'd had febrile seizures. So if the parent has a history of seizures or febrile seizures, you have to immediately think, could that parent be mosaic and have an increased recurrence risk? That father is now my patient. He's about 48, and he's having tonic seizures actually in adult life. So it's not quite as mild as it sounds. Now, in this other family where I have a mosaic parent, the mother was 17% mosaic, and she's very normal. This father's normal-ish, It's not the brightest. This woman's very bright, and she is 17% mosaic and only had febrile seizures and has a mildly affected daughter for Dravet syndrome. Now you can see they've had 3 children, but she was lucky, only one of them got Dravet syndrome. And in fact, I've just got one of the 2 new ones that I've just diagnosed. The father is mosaic, so we've now got another family. Now, this story that I've just been sharing you was part of this paper that we published, but the take-home message relates to every child you see. Can you hear me okay?
Yes, we can.
Great, thank you. I can just hear a bit of an echo. Every child you see with a developmental and epileptic encephalopathy, and in this study we had 120 children with developmental and epileptic encephalopathies, and their parents had been tested and were negative for their child's mutation. And we looked at these 120 families, and we looked at the parents 200 times for their child's mutation. And each family had a mutation in one gene, but across the 120 families, we had 33 different genetic disorders. And we found that we have underestimated parental mosaicism, and that 8% of our patients had a parent who was mosaic, even though the parent had been thought to be de novo. And this puts them at markedly increased risk of a second affected child. This is a picture of a family I care for with 2, a boy and a girl with DNM1 mutations. And this is really your worst nightmare, where you have to have 2 wheelchairs because neither child walks or talks. And sadly, they have no further other children. And father is 6% mosaic. Parents are very normal. So the red flags to us clinically is if the parent has had any seizures, including febrile seizures. You should think before they have a second child, could the parent be mosaic? And if the parent has had more seizures or has epilepsy, that should worry you even more, that that parent is mosaic. And this is across all of the developmental and epileptic encephalopathies. So I've just dealt with the mosaic patient issue and the mosaic parent issue. The other inheritance pattern for Dravet syndrome is that you may have a mutation that is inherited from a mildly affected parent with GEFS plus, genetic epilepsy with febrile seizures plus. Now, as you know, this is a spectrum, and the most mildly affected people may just have febrile seizures, which 3% of the population have. So you need to think about it here. Now, if the parent and the child are heterozygous and there's no mosaicism, that then implies that the child must have additional genetic factors that are contributing to their more severe phenotype. So this just takes me to the end of my puzzle, and this is really what we've taught for many years about whether Dravet, about the complex diagnosis of Dravet syndrome. So in the study I wanted to share with you, we asked the question, are these criteria for Dravet syndrome actually correct? And the reason I asked this is I'd seen many patients who have what I call fuzzy edges. I don't know how that translates to Spanish, but where they looked like they were Dravet, but they didn't fit the puzzle very well. So the questions we asked were, when can you diagnose Dravet syndrome? Do you need to wait till they're 3 years old and they have all the features? Can you diagnose it when the baby presents with their first episode of status epilepticus? Can you diagnose it with their second episode of status epilepticus? What if they feel a bit like Dravet syndrome, but they're not quite right? So this study was performed with 2 of my colleagues. Dr. Wanhui Li came to work with me from Shanghai for a year. Her English wasn't very good, so I got her to look into all the files, and this was a year of her work. And then I worked very closely with my chief clinical research scientist, Amy Schneider, who is fantastic, and the 3 of us brought this work together. So the aim of this work was to refine the classification of Dravet syndrome. And I see it as a little bit of as a example of what we should be doing with all of the developmental and epileptic encephalopathies. This is just the first, but there are many more. And we need to understand what are the limits of such a syndrome. How can we make a diagnosis if the patient has features that don't quite fit? And you could say, well, why am I being so pedantic and worrying about the small print? And that's because we know if you give the wrong drug, you can make the child worse and have an impact on development, and that these wrong medicines can therefore leave the child with a worse cognitive outcome. The other reason, of course, and this is a very hot and exciting topic, is that of precision medicine trials, gene therapy, and there are now 2 gene therapy trials at least starting in Dravet syndrome. So you want to diagnose these babies at 6 months of age so you can get them before their development falls away. And just to make this point a little bit more strongly, this is a 2018 seizure diary of a patient being seen by a very senior and excellent paediatric neurologist in Melbourne, and not an epileptologist, but a very good paediatric neurologist. And you can see here the red lines denote the baby's presentation at 5 months of age with 2 convulsive seizures. Just some after, they started some levetiracetam at this point, and I think the parent put together this picture. Still some seizures, but they weren't really coming under control. So my colleague started trileptal here, oxcarbazepine. And you can see here, what does the oxcarbazepine do? Triggers a whole lot more seizures, causes seizure exacerbation, and that of course affects development. And this is all because my colleague did not think in this baby, could it be Dravet syndrome? So in this fuzzy edges, I call it, study, we looked at 205 patients through our research program that we had good data on with Dravet syndrome, and they had SCN1A mutations. So you will recall there are a few patients with Dravet syndrome that have other genes, but they're only a handful. And so we looked only at those with SCN1A mutations. And we analysed the early clinical features based on parental interview, a validated seizure questionnaire we've used for about 30 years, and medical histories. And here is the cohort, 205 patients. Median age at study was 8.5 years, but you can see the oldest was 60 years. And the range for this study, which we completed the data a couple of years ago now, was 10 months. And this is just the breakdown of the mutation data, which, as I said before, has stood the test of time. 40% truncation, 40% missense, and then a selection of other different types of mutations. So let's walk through the puzzle and see what actually is correct in what we've been teaching. So I said at the beginning that the mutation is, the presentation is usually at a mean age of 6 months of age. And one of my very senior colleagues, who I think is fantastic, teaches that the onset is under 12 months. Now, I've never been quite sure that was correct. So we looked at that carefully. And here is the data from our 205 cases. And the median onset was exactly as you'd expect, 5.75 months, so almost 6 months. And here you see our 12-month mark. But you see in our data set, we have a number that have begun after 12 months, and these X's, you'll recall, denote a truncation mutation, so they're not just milder cases, and they're beginning after 12 months. Now, the other thing is that some of them, also after 12 months of age, are missense mutations, as you can see here. So both sorts can begin after 12 months of age. What about the literature? Well, when you go into the literature, you do find quite a lot of other patients that begin after 12 months of age. So the 12-month mark is wrong. And I now, if you're talking about heterozygous cases, they can begin up to 19 months of age. And the other major point I wanted to point out is about this mosaicism issue. So this is a little girl I saw. She began at 20 months and she is mosaic herself, so only 22% of cells. So it sort of makes sense if you're mosaic, you're more mildly affected. And that goes with both the Dutch data I showed you and the parental data I showed you. But is this always the case? And the answer is no. So we did have other mosaic cases in our study, and you can see some of them begin right at 6 months. And this one is particularly interesting, and we've published it as a case report. But it was a child with very low levels of mosaicism, 8 and 7%. But interestingly, the same allele was mutated in two different amino acids. So very interesting, makes you ask, why would that allele be particularly susceptible? But we're not the only ones who've published on that. And I mentioned that lovely Dutch study, and here you can see their mosaic cases. So this shows very clearly that if you're mosaic, it doesn't mean that you're necessarily having a later onset. So let's tackle the next question, and that is, what about the first seizure type? We teach it should be with a fever. We teach it's prolonged status epilepticus, which is more than 30 minutes. We teach hemiclonic, makes you think of Dravet, and it should, but what about generalized tonic-clonic seizure? So the first question is, do you have a fever with your first seizure? And we went back to the source data. And by that, I mean the actual hospital file. And interestingly, just over 55% had a fever with their first seizure. So what we're teaching there is not quite right. I think this is a very helpful point for diagnosis of Dravet syndrome, which is that they tend to fit with a lower fever. So, you know, if a child presents with a prolonged seizure or a febrile seizure of 40, 41, 39, 41, that's very normal for the 3% of children with febrile seizures. But Dravet kids tend to fit with a lowest fever. And strictly speaking, I wouldn't even call 37.7 a fever. I would say you have to be over 38. 3% of our cohort never had seizures with fever. And indeed, the boy that I've just diagnosed has never had a seizure with fever until about he's just had one recently in the setting of a viral illness, but he'd probably had about 7 presentations before that. So what about the first seizure type? And you can see that whilst we teach hemiclonic and the alternating sides in different seizures, I think that's really helpful, because if you've got that diagnosis, like in that baby I just showed you, it's, you know, pretty definitely going to be Dravet syndrome if they're in different sides. But look here, more than half of the patients presented with a generalized tonic-clonic seizure, not a febrile seizure. And what about the rest? You can see some present first with a myoclonic seizure, and then they may be shown, you know, weeks or months afterwards to present with one of the other seizure types. Focal impaired awareness seizures, remembering that's the old complex partial seizure, that's the new name, multiple seizure types at once, and rarely with absence seizures. So take-home message is that the generalized tonic-clonic seizures are more frequent than the hemiclonic seizures. So the next question is, let's think about duration. We tend to teach that they present with status, but indeed only a third present with status. Quite a lot present with longer seizures, 6 to 29 minutes. But there are some that present with just brief seizures under 5 minutes. And in fact, some patients never have status epilepticus. If we drill down on this 20%, 27%, you can see that still 17% present with their first seizure with under 1 to 3 minutes, and some of them 9% with 5-minute seizures. What about their first 5 seizures? Well, you can see here that of the first seizure is status in about 30%. The second seizure is in about 20%, and this goes down. And you can see that briefer seizures become more frequent by their 5th seizure. That means under 5 minutes. But the other point I find helpful clinically, is that many Dravet children, I think, specialise in longer seizures. So you can see that most of the seizures here are more than 5 minutes. So if you have a baby that keeps coming in with 6, 8, 10-minute seizures, think Dravet. It's another very helpful thing. And then we looked at the median duration of the first to the fifth seizure for each child. You can see they're getting shorter, and you can see there are some children that still have status epilepticus. But importantly, it's not always status epilepticus. So another way we've thought about looking at it is what's the days between the first 5 seizures? Because I just taught before that you know, you might have your first seizure at 6 months and come back at 7 or 8 months with your second seizure. But this is not always the case. So the median was 30 days. So that's why we talk about it in a month. But have a look here, the outliers, and there are quite a few outliers here that are more than 6 months. And then you can see here there are quite a few that might be 5 months. So you should still think of Dravet. What about the second to third seizure? Same median, same outliers. So you just need, they probably are getting a bit tighter, but you can see that they can still be a long time between their first, second and third seizure. And interestingly, when you go third to fourth and fourth to fifth, they become much closer together. So again, you need to think about this a little bit differently. Now, what about other seizure types? And I've already explained that they can present with a median age of their first seizure at 5.75 months, but they can begin here at 1.5 months. So 6 weeks was our youngest, and we've talked about our oldest being 20 months. So this is really about what about their next seizure type? When does it happen? And I've always taught from 1 to 5 years, which is what Charlotte Dravet taught me, I think. And when we looked at it, that's not actually quite right either. The median of age of presentation with a second seizure type was at 9 months, but began as early as 3 months, obviously in those beginning before. And look at this, as late as 25 years. What about the third seizure type? Well, the median is 15 months, so again, much earlier than I would have thought, with the minimum at 4 months and the maximum at 8 years. So what are these additional seizure types? Do they all have all of them? So the answer is no. 4% never have tonic-clonic. 70% have hemiclonic at some time in their lives, but importantly, almost 30% do not. 70% have myoclonic at some time, 70% focal, absence in about 60%. But look here, tonic and atonic seizures also occur. Now, we know from some nice French work that tonic seizures are more likely in adults, but it's a quarter of patients can have tonic and almost a quarter atonic. And these can be in younger children predominantly. And I know that Charlotte Dravet had not seen that herself years ago, but we've now found that. So that's also a bit of a trap you need to think about. 11% never have convulsive status epilepticus, defined as 30 minutes, and about a quarter have non-convulsive status epilepticus. I remember actually seeing a severe Dravet when I was visiting in Santiago, a little girl with quite a severe tremor that you showed me. Now here, look at the seizure types by time, by type rather, and you can see here tonic-clonic seizure in orange, and this is now not the percentage but the number of patients. So 100 out of about 205, or here we had data on about 190, good data. 100 of 190 presented with a tonic-clonic seizure, whereas about 70 presented with a hemiclonic, and this is the data I showed you before. But this shows the evolution across different seizure types over time. What about developmental? Well, developmental slowing, we tend to talk about it as starting after 1 year of age, but that's not quite right. And what we found was that over a quarter present with slowing prior to 1 year of age, And you can slow as late as 5 years of age. So I remember seeing one little girl I look after, well, now she's 28, but when I met her at 6, she was normal and she slowed later. So here it is important to know that only a small percentage, 4 patients, 2% presented with delay prior to seizure onset. So that can happen, but it's rare. And the median age of slowing or plateauing is 20 months, but that range can be anywhere from 3 months to 5 years of age. We've talked about the EEG, and we haven't really focused on the EEG studies here because you can't always get that data, but basically generalized spike wave, polyspike wave, and multifocal discharges. And the other point I wanted to touch on for a couple of slides was around the mortality. Now, this Cooper paper in 2016 was on our same cohort, which has expanded subsequently, but just to look at the different types of presentation. And you can see here that Dravet patients have a mortality risk throughout life. I don't think it goes away, but it is probably higher in pediatrics and under 12 years of age. About half die with SUDEP, sudden unexpected death in epilepsy, shown in black. Some of them have asphyxia or accidental causes like drowning. And then there's this important group here of cerebral edema, where the patients present with swelling. Now, in this paper with Monica Cooper that we wrote, we came out with a Dravet-specific mortality rate of 15 per 1,000 person years, and this shows the SUDEP rate of 9 per 1,000, so it's more than 50%. I just wanted to touch for one slide on this issue of cerebral edema. And this is a very worrying syndrome where we found in children all presenting with febrile status epilepticus. One was not known to have Dravet, though I had seen her and made a provisional diagnosis, but they didn't get the testing done, the molecular testing done in time. And these children present with status epilepticus, and then they don't wake up the way you would expect them to. And so after about 12 hours or a few days, they suddenly do an MRI, and the MRI shows profound swelling of the brain, loss of grey-white matter differentiation, and you can see the watershed areas here in this swelling. And they never wake up. They have fatal cerebral edema, which you can see on this H&E stain. So what about the genetics? Are only 80% solved? So I wanted to show you this from our data set. This is from a slightly earlier point in time where we made a diagnosis of 138 definite and 159 probable Dravet syndrome. And we now find that 93% of the definites and 92% of our probables had SCN1A mutations. We, in fact, wrote the paper describing GABA-G2 and A1 as being causes of Dravet syndrome, and others noted that SCN1 and B could be causing Dravet syndrome. So the take home from this is that more than 90% are solved, and more than 90% have got SCN1A mutations. So to walk through what I've just gone over, this is the classical teaching that we teach our students, and this is the evidence. What does it tell us? Well, you can have delayed development prior to 12 months of age in a quarter of the patients, some of these even prior to seizure onset, but some of these clearly after seizure onset, most of them after onset. The first seizure, not febrile, begins between 6 weeks of age and 20 months. The most common presentation is with a generalized or bilateral tonic-clonic seizure in more than half. Afebrile initial seizures are present in 45%, and status epilepticus occurs in about a third, but just as many, almost as many, present with very brief seizures under 5 minutes. The mean onset of other seizure types, or median onset, I should say, is under 12 months for the second seizure type. A third never have a hemiclonic seizure. 7% never have status epilepticus. There is no fever sensitivity ever in 3%, and about a quarter have tonic and atonic seizures. So if we look at our puzzle, you can see that much of what we've taught may be not quite right, and we have to rethink that. So that's the end of Dravet syndrome, but I did want to talk about the pointy part of this pyramid. So when we talk about SCN1A epilepsies, we talk about the mild self-limited end of genetic epilepsy with febrile seizures plus. We talk about the largest group of Dravet syndrome, but I also wanted to touch for a moment on the most severe SCN1A phenotype, which is the early infantile developmental and epileptic encephalopathy. And this is a profound disorder which we discovered in 7 patients originally, and 6 of them had this one specific missense mutation. So remember, missense people think is milder, but this is much more severe. So just to use my puzzle again, in this paper we had 7 boys. By chance they were boys. I think that the fact they were boys, all boys, was chance. They were aged at the time of study 6 to 12 years. They had onset under 3 months rather. So remembering that Dravets can start under 3 months, so can this one, and it looks a bit different. 5 of our 7 presented with hemiclonic seizures and 2 with generalized tonic-clonic seizures. And this is the point of major difference. They had early onset of tonic seizures and or epileptic spasms. Now, I've never seen epileptic spasms in a Dravet patient. So if you're seeing spasms, you should be thinking about this phenotype. It's not clear if these children were absolutely normal from 6 to 12 years of age, 6 to 16 weeks of age, as nobody noted they were abnormal, but one wonders how critically they were examined. These children all have profound impairment. They're non-verbal and they don't walk. They have a very interesting movement disorder that begins with between 9 weeks and 20 months. And here you'll see a video of 3 of the unrelated boys, all with the same mutation. And they have this hyperkinetic movement disorder with chorea, dystonia, and this very interesting feature of orofacial myoclonus. I don't think this is specific to this disease, but I do think it's a very distinctive feature and certainly something I've never been able to get under control. The EEG was initially normal despite them presenting with many seizures, but you can see they then developed generalized and multifocal abnormalities on EEG, epileptiform abnormalities. And 6 of our 7 had a recurrent threonine 226 methionine missense mutation. And so we conjectured that this actually may have the opposite functional effect, that this, we know Dravet syndrome and GEFS plus is associated with haploinsufficiency, truncation mutations, loss of channel function. There are lots of very good functional studies to show that. So we thought these SCN1A early infantile developmental and epileptic encephalopathy patients looked more like the SCN8As and 2As, and we thought was likely to be gain of function. And I'm very pleased to say that my physiology colleague, Geza Barecki and Steve Petru, showed that this was indeed right. The other point I want to make is there are now several other mutations associated with this profound phenotype. So you don't just have this mutation, and I'm collaborating on a study where they're putting together a number of other patients with this profound phenotype, including some other recurrent mutations. So I'm almost at the end. I just wanted to say that we've hopefully made it not so fuzzy, Dravet syndrome, by understanding the phenotypic spectrum, allowing early diagnosis, the correct therapy, not carbamazepine, and yes, valproate, yes, topiramate, clobazam, CBD, fenfluramine, and we're getting ready for precision medicine trials. And in this paper, we've published an algorithm which might be useful to you. The paper is on free download because of the Spanish Dravet Syndrome Foundation people let me know about a grant they had to allow open access, which is not cheap. It's $5,000 of our dollars, and they paid that for us so that everyone around the world, including our families, could access it. And you can see here really what I've just shown you about the first seizure, the duration between the seizures, the seizure types, the development, and the over life, whether they develop convulsive seizures or may never have fever sensitivity. So in conclusion, I'd like to particularly thank Wang Hui and Amy for their work on this study. This is one of the family conferences that I ran for families whose children have developmental and epileptic encephalopathies. And here you'll see the little guy that I just showed you with the profound phenotype, who he comes along to the conferences as well. And I'd like to close by thanking the many people around the world, the collaborations, including the Chilean collaborators. Thank you very much.
Agradecemos a la profesora Scheffer por su brillante presentación y ahora procederemos con la sección de preguntas y respuestas que han hecho a través del chat. Uno de los asistentes pregunta respecto a la fenfluramina. ¿Desde qué edad se podría utilizar y qué cuidados especiales habría que tener? ¿Hay algún grupo que esté en este fármaco que impresione tener mejor respuesta que los otros? Okay. Dr. Scheffer, the first question is regarding fenfluramine treatment. Is there a minimum age to use it? Is there any special care to have when you have patients on fenfluramine? And have you identified any subgroup which could benefit the most from the use of fenfluramine?
Okay, I'll try and remember all those. You may have to ask me again, Philippe, if I forget. But basically, I think fenfluramine is the best drug we have. Sadly, at the moment, I do not have it because it costs 120,000 Australian dollars. Americans probably 100,000 a year for an adult-sized patient, and my families do not have that sort of money. I'm sure it's the same in Chile. So I've been pushing the company to try and bring it to Australia. In fact, I had a meeting with them last week, but Australia is well down on their list because we don't have enough of a population. So I can't get it. I do have some children and adults on it because I was involved in the trials. And so I can tell you when it's good, it's fantastic. And it's much better than any other drug we have. So if it was my patient, my child, and they presented at 6 months and I diagnosed Dravet syndrome, I would pay for that for my child, just to be clear. In terms of when should you start it, I don't remember what the bottom age in the trials is. I'd have to look at the papers, but still I'd start it as soon as I could if it was my patient, because I think it's the best drug. If all we can do until we have gene therapy is control the seizures, and if you can stop the seizures, you see that the children do better. And a lot of the parents will tell that to you. You know, if the child hasn't had a convulsive seizure for a few months, they're learning, they're developing, they're doing much better. So I think I would start it as soon as you can. In terms of you, is there a population? Not to my knowledge. I don't know if it does anything in that profound group. We haven't tried it. The third thing was side effects. It is a bit of a temperamental drug. So one thing I do advise is starting really slowly, low, and go slow. And by that, in a little one, I often will start with 125 milligrams, depending on the size of the baby, and maybe take it out, increase it every 2 weeks. And if they get anorexia or vomiting, then I would reduce it and go even more slowly, because it can be very temperamental with weight loss and gastrointestinal side effects. The other thing that you have to worry about is just watching the levels of the other drugs a little bit, the valproate and the clobazam, if they're on that. I think I answered all the questions. Was there more?
No, you have. Is the last question, is there any subgroup which would benefit the most? Have you identified within
No, there is no subgroup. So the interesting thing is that I was involved in the fenfluramine for the kids trial and for the adult trial. Unfortunately, right at the end of the recruitment, it took a long time for them to put us through ethics here. But in the adult trial, I had a lot of patients, I think compared to, I only had 50, and I think I had, I don't know, 5 to 10, I don't remember, of Dravet and LGS. And of the Dravet, it was really good for some and didn't do much for others in the adults, but certainly worth trialing. And in the LGS also, it was very good for some and didn't do much for some of the others. But don't forget that Lennox-Gastaut syndrome is very heterogeneous.
La siguiente pregunta es respecto en un paciente que se inició tratamiento, que ha fallado el ácido valproico. ¿Cuál sería su segundo tratamiento de elección? ¿Cannabidiol o stiripentol? In a patient who has already started on valproic acid, which is supposed to be the first choice, and what would be your second anti-seizure medication? It would be either cannabidiol or stiripentol.
Good question, thank you. So I think, so again, it's a bit money related, my response. In Australia, CBD, so the first thing to say is there are many cannabidiols. The only pharmaceutical grade one in the world that is FDA approved is Epidiolex. And I've been involved in their trials. I had about 12 Dravets in their trials. And in fact, I've just published 2 CBD papers in the last 2 weeks, one on Epidiolex and one on a gel from Zynerba. And so Epidiolex has just been approved in our system. And you'll think I'm obsessed with money, but it costs $20,000, $25,000 a year for an adult-sized person, and they've only approved it over 2 years of age. So I don't think Epidiolex or CBD, so in terms of non-Epidiolex CBD, I worry about using it, to be honest, because you don't know that what you're giving the patient is the same dose every time. And the other big worry is THC, because I worry about the risk of psychosis in later life. And how do we know that giving THC to a 3-year-old brain doesn't mean that they'll be at risk of psychosis later in life? So in an ideal world, I would just use Epidiolex, excepting, but even the other ones, we have Tilray here. It's not pharmaceutical grade and they're charging just as much money. So we should be paying our money for the one that's properly made. The Zynerba gel that I've just published on about a week ago in JAMA Network Open, it wasn't a real trial, it was an open label trial, but it was just proof that it works. It is pharmaceutical grade, it's synthetic, but it's not FDA approved, just to give you an idea around that. So that's the first. What about stiripentol after valproate? So, and the other drug that gets forgotten a bit is topiramate. I think it's a great drug in Dravet syndrome, and people always worry about the speech. I've seen many children with Dravet syndrome, you give them topiramate and their speech actually improves. So I'm not a believer that it's the worst thing. I've also seen some where you stop it and it improves. So I'm not saying it doesn't happen, but I just think it's underrated for Dravet. My view, and I have published a paper on our experience with stiripentol, is that stiripentol is very good for status epilepticus. I've had numerous kids where I've used stiripentol and they've gone from having lots of admissions for status epilepticus to having none. So my experience is that, and I've used stiripentol for probably 20 years now, that stiripentol is really good if a child's presenting with lots of long seizures. And I have to say in this one that I just mentioned a few times, the 7-monther and the little girl I showed you, who's 12 months, I've started them very rapidly on stiripentol. And in Australia, you're meant to do it with valproate and clobazam. So I've given them a taste of clobazam. a little bit, 1 milligram for one of them, and then I've added in stiripentol to try and get on control of the status, because if you stop the status, you can stop the regression. Sorry, is that too long an answer?
How did you administer in that case, in the case of stiripentol, in the setting of status epilepticus? How do you administer?
I'm not giving it at the time of status, but starting them on it. And I also started very slowly. In fact, I just told you the dose of fenfluramine, and I was talking about stiripentol now, I realized. When I said 125 milligram, that was stiripentol, not fenfluramine. So please, nobody get that wrong. I got that completely wrong. So the stiripentol, though, I learned to start it very slowly and low. And if the baby got anorexia or vomiting, just to bring the dose back, halve it or make it every second day, make it less, and then you build it up. And I think stiripentol is really good for long seizures. So that's my favorite place for stiripentol. But with stiripentol, your valproate should not be above 30 milligram per kilogram per day, and clobazam should not be above 0.5 milligram per kilogram per day. Would I go stiripentol or CBD? I think in an ideal world, I'd still go stiripentol ahead of CBD, to be honest.
Aprovecho de preguntar respecto al stiripentol. ¿Tiene alguna experiencia con el uso de stiripentol en estas formas más leves del espectro SN1A? I take advantage of asking a question of my own regarding stiripentol. Do you have any experience with stiripentol in the treatment of these milder forms within the SCN1A spectrum? Do you have any experience with stiripentol, for instance, in genetic
Gibbs
plus genetic for instance?
I wouldn't use it there, to be honest. I don't think you need it. In Gibbs plus valproate usually works. Or you might go clobazam or topiramate. I wouldn't even begin to think about it. So I would use it just stiripentol in Dravet. And as I mentioned, I don't know how good it is in the profound phenotype. I'd certainly try it. I think I have tried it in my little one, but I don't remember. Nothing's helped him. Actually, CBD has helped him, but the family, this is the profound phenotype, I'm talking about the early infantile, but the family is very alternative. In fact, I'm due to see him next week. And I'm not sure whether there's a bit of, I'm not sure that we know for that phenotype.
Hace algunos años, los japoneses desarrollaron un score para predecir qué pacientes con crisis febriles podían evolucionar con síndrome de Dravet, por lo tanto debían ser testeados precozmente para SCN1A. ¿Estos criterios son aún válidos? Some years ago, a Japanese group developed some prognostic criteria for the development of Dravet syndrome in the context of early onset febrile seizures, and thereby to determine which patients should be tested early for SCN1A mutations. Do you think that criteria are still valid?
I think you're talking about a paper by Hattori.
No, that's right. That was a Japanese group.
I have to say, I never thought it grasped it. So I haven't compared our data with it, but it's one reason, I'm not mad on those sort of things, tick boxes. And I think the Dravet syndrome, and in fact, much of syndromology is about a gestalt. I hope that translates to Spanish, gestalt, but it's recognizing a pattern, which is why I put together my puzzle. And I know I've shown that puzzle when I visited Chile. And I just felt that ticking that thing doesn't work. It would be very interesting actually to see how our data go against that box, but it wouldn't be, if somebody wants to do it, I'd be interested to see it, but I don't know how publishable it would be. You're on mute, Philippe. Yeah.
Oh, no, turn me on now. Okay. En pacientes con clínica compatible con Dravet y panel genético negativo, ¿Cuáles, cuándo y cómo estudian mosaicismo en un setting clínico? In a patient with a Dravet syndrome and negative panel, negative SCN1A mutation, how do you study the mosaicism? How do you usually study mosaicism? I think you have already explained this. So
let me explain a little bit more though, because I think mosaicism is becoming more and more important. And we all have mosaicism in our brain. It's fascinating, actually. When they looked at single neurons from 3 people who died, who were normal neurologically, car accidents, there's a fascinating paper from Chris Walsh from Boston in Science, or from about 5 years ago. And they looked at each 3 neurons from 3 people and single cell sequenced them. And we have an average of 1,500 changes per neuron, all right, from the regular background single nucleotides in our brains. So we're all mosaic. I think the first thing to say, and this is from the last 20 years of experience, when we first published a paper with Dravet syndrome, we looked at about 24 patients in 2003, I think it was, and we had a 33%, a third were positive, 8 of 24. And the technology wasn't good enough. Then we've done more and more, and as the technology's improved, those that were negative have all come out positive with different types of mutations. And I think there are almost none left, maybe 5 left out of, and I only showed you 200 in that study, but we've got many more in our studies. These were where we had good data that we could analyze it. And, you know, even another one, we described a poison exon about 2 years ago with Gemma Carville. And one of my adults that I've been going for years, is he Dravet, he's severe, and he had this poison exon. So it's more a matter of getting good enough molecular testing. Now, to answer the question around the mosaicism, we can generally only access saliva or blood. We can't get brain, and we can do CSF for research purposes, but CSF at the moment is only working when you know the mutation. And we know that for most patients with Dravet syndrome, we don't know the mutation, and it's not a recurrent mutation, so the CSF doesn't work. So, I mean, what I recommend is go back and look again, get genome sequencing, maybe it's in the intron, this poison exon was in the intron. Make sure you've done copy number variants, so you have your chromosomal microarray, but that can miss a small intragenic or a small gene deletion. That should pick up on genome sequencing. So look at it more cleverly is the way I would do it.
¿Cómo se manejan los movimientos anormales en el contexto de un síndrome de Dravet en particular? How do you manage the abnormal movements in the context of an SCN1A encephalopathy? In the very profound one, you mean? Yeah, in the one, the early onset, development, an epileptic encephalopathy. I don't know how to manage them. I don't think anything makes any difference. But if somebody else has found something, please tell me. Well, what would be your suggested treatment algorithm? Or you probably would start with valproic acid and then. Oh yeah, sorry. I thought you were talking about the movement disorder. If you're talking about I tend to change the subject. No. Okay, the epilepsy, I do have very strong views on. I think that we should use sodium channel blockers, just like you would with SCN2A and SCN8A. So by that I mean carbamazepine, oxcarbazepine, phenytoin, and people are saying we should use high dose and that it works better. I don't know that that's a proper trial. It's not, but I do think that's where I would start with those patients. I would be using carbamazepine very early on, or phenytoin. Now, the problem is, how do you know whether you're dealing in a 6-weeker with the Dravet or the early infantile? I guess if you have spasms, it's the early infantile. If you have
a recurrent mutation that we know is early infantile, it's early infantile. If you have a movement disorder, it's early infantile. But the others, if you use carbamazepine or phenytoin, you might make them worse. So I think you have to just tread, very carefully with that one. Did that make sense?
Do you have alguna experiencia con fenobarbital? Do you have an experience with phenobarbital?
Yes, no, I don't. I've got 1 or 2 Dravet children who are on phenobarbital because they're still on it. I never use it. They always say if you could ask the neonates, they'd say no, thank you, to phenobarbital. And it's a pretty dirty drug in terms of side effects, behavioural. I wonder if I underuse it a little bit. I'm beginning to feel the opposite way, that maybe I should be using it, maybe in the more severe ones. But in general, I don't use it and I don't like it. I have one patient I can't get off it, and she's probably about 8 now.
Estamos ya en el tiempo, así que esta será la última pregunta. Existe, dado que la principal causa de muerte en el contexto del síndrome de Dravet es el SUDEP, ¿existe algún programa para prevenir SUDEP? No? Since the main cause of death in Dravet syndrome is SUDEP, do you have any program to prevent it? Do you have any protocol? Do you have, what's your experience in the prevention of SUDEP in the context of Dravet syndrome, since it's the first cause of death?
Yeah, so there's a lot of anxiety with families about how do you prevent the child from having SUDEP. The first thing to say is there's nothing known in terms of proven to answer that question. The second thing is people say, well, what's the best way to monitor a child? Is it an oximeter? Is it a respiratory mat? Is it a heart rate monitor? Should I sleep with the child? I'm sure in Chile, lots of the parents sleep with the children or have them in the same room. And I completely understand that. And I think it's very reasonable. I think what I say to Australian parents is, I think there's nothing proven, but I would use an oximeter. The problem with an oximeter is that it only goes off once the child's almost dead, because your oximetry only drops at the last minute. What we don't know is if you then go and give the child a gentle shake, does that get your brainstem firing? And we know from the Mortimer study that SUDEP occurs tonic-clonic seizure, respiratory stop, then heart stop. So the question is, can you make the child's brainstem activate? I think it's an important question. The other thing that, again, may be more common in Australia is I'm encouraging families to get a camera in the room. And there's a camera that here called a SAMI camera. I don't know where it's made. And it actually does very nice recordings in low-level light and will go off if the child makes abnormal movements. But what we don't know is, do they always make an abnormal movement for a SUDEP? And just by way of example, one of my most anxious families in Dravet land was the one where I just showed the father was affected with the boy and the girl. And the whole family had influenza. The girl was about 11. The mother had spent much of her life staying up all night to watch both children. I do not recommend this, but she was so anxious. On the night that the little girl died, she was laying next to her on the edge of at the bottom of her bed at 2:30 a.m. She was awake till then. She fell asleep, and at 3:15 she was dead. And she was next to the baby, the 10-year-old. And so she didn't feel a seizure, so we don't know if she ever had a seizure. This mother is like this, so I suspect she would feel a seizure. And, so we really don't know what causes SUDEP.
Bueno, ya estamos en el tiempo. Agradecemos la importante convocatoria. Tenemos más de 100 personas presentes de distintos países de Latinoamérica, entre ellos Panamá, Ecuador, Nicaragua, Argentina. Así que les agradecemos a todos por su atención y por sus preguntas. Y más importantemente a la doctora Sheffer por su brillante presentación y excelente disposición para responder todas nuestras inquietudes. Finalmente, los quisiéramos dejar invitados a nuestro próximo webinar a realizarse el día 15 de octubre con el tema El rol de la genética en la cirugía de la epilepsia, el que será presentado por el doctor Chris Brown de la Universidad de Utrecht de los Países Bajos. Nos vemos y que tengan muy buenas noches. Okay. Well, Dr. Schäfer, thank you very much. We're truly thanks with me. And we like to thank you again for all your time and readiness and your great disposition to answer all our queries and presence.
Great, thank you very much.
Thanks to you. It has been a pleasure. Okay, take care. May you have a good morning there in Australia.
Yeah, and have a good night there. Bye-bye.
Okay, bye. Take care.